Hello everyone, so I'm back again, but this time this is the much awaited guideline summary, which is management of inherited bleeding disorders in pregnancy. I worked quite hard on the slides just to make it look simple and also in a format that is easy to follow and hopefully the one that you can understand and memorize for your exam. So please don't forget to give this video a thumbs up and subscribe to my channel if you haven't already. And please do comment on the video to tell me if you found these slides useful and if there's anything else that you would like to watch. So topics covered are haemophilia A and B, 1 Willebrand's disease, factor 11 deficiency, rare factor deficiencies, fibrinogen disorders, Bernard Soulier syndrome, which is shortened to BSS, Glanzmann's thrombocythemia, and other platelet function disorders. Okay, so we start with hemophilia. It's an X-linked condition. It's a reduction or absence of clotting factors, mainly clotting factor 8 and 9. So if there's an absence of clotting factor 8, that is hemophilia A. And if it's clotting factor 9, then it's hemophilia B. It can cause bleeding into joints and muscles. So we see that for the 50% of neonatal males that are born with this condition, there's actually no family history. So it's likely that in these cases, 90% of mothers are actually carriers, and there's a risk of having a future male child who can have severe hemophilia. So a family tree should be constructed and all the at-risk female family members should be pointed out. Genetic mutation testing can be done for the family if they're available. This requires written information consent, but it should definitely be offered. So what are the risks in the pregnancy to the mother and the baby? So for female who are even just carriers, they can have low factor 8 and 9 levels. This means that these levels should be checked before invasive procedure is carried out because it can increase risk of bleeding in things like termination, spontaneous miscarriage, and a delivery. With male neonates who have hemophilia, there's increased risk of bleeding, so they can have intracranial hemorrhage, extracranial hemorrhage, iatrogenic bleeding following delivery. So what is the pre-pregnancy management? So baseline factor levels should be tested and checked. General health of the patient should be managed, so things like weight management and correction of any iron deficiency to help start off with good hemoglobin levels. What are the options for prenatal diagnosis, so shortened to PND? So pre-implantation genetic diagnosis should be offered to carriers of severe hemophilia. Fetal sex determination by free fetal DNA analysis from 9 weeks of gestation should be offered. If the male fetus is affected, then the patient should be counseled about choices of either continuing on with the pregnancy or for termination. Pregnant carriers should be offered prenatal diagnosis with chorionic villus sampling at 11 to 14 weeks of gestation. If for any reason this has been missed, then offer a 3rd trimester amniocentesis if no diagnostic investigation has been carried out to determine hemophilia status, so you can discuss mode of delivery. Okay, so what is the antepartum management? So it's an MDT approach, so you include the hematologist and the obstetricians. Factor 8 and 9 levels should be tested at booking of the pregnancy and before any antenatal procedure is carried out and in the 3rd trimester. Generally, factor 8 levels tend to rise in pregnancy, but 9 levels tend to remain stable. Aim for factor 8 and 9 levels of at least 0.5 international units per mil to cover any surgical or invasive procedures or spontaneous miscarriage. If treatment is required, factor levels of 1 international unit per mil should be aimed for and not allowed to fall below 0.5 international units per mil until hemostasis is secure. Tranexamic acid combination with treatment for levels less than 0.5 international units per mil, or as sole therapy for those with levels above 0.5 international units per mil if clinically indicated. Following miscarriage, tranexamic acid should be continued until the bleeding settles. Desmopressin or DDAVP can be used antenatally to raise factor VIII levels. Recombinant factor VIII levels can be used. So recombinant factor VIII can also be given to help raise factor VIII levels if a treatment to desmopressin has still not resulted in sufficient levels, or the patient is a non-responder. Recombinant factor IX is required to cover any invasive or surgical procedure, as women with factor levels who have got less than 0.5 international units per mil. Intrapartum care plan for the patient who may be a carrier or and the baby should all be documented in the notes, especially before 37 weeks, just so everybody is clear of the plan. The patient should be seen in a high-risk anesthetic clinic, and also the neonates should be informed of the plan for delivery. If there's no antenatal diagnosis of a male fetus and the female is even just a carrier, then it should be assumed that the baby does have the condition. For ECV is avoided in affected or potentially affected male fetuses and female fetuses who are obligate or possible carriers of severe hemophilia B. So what is the optimal mode and timing of delivery? And this is something that needs to be agreed and discussed between the patient and the MDT team looking after the patient, which includes the hematologist and the obstetricians and the anaesthetists and the neonatal doctors. So the option of a planned cesarean section should be discussed, especially for delivery of affected male babies, especially those with severe hemophilia, and or if the fetal status is unknown. However, there needs to be a full assessment and of the advantages and the disadvantages of this mode of delivery, and the consideration of obstetric factors, maternal bleeding risk, patient preference, and reproductive expectations of the patient. If an elective cesarean section is agreed, that can be done at 39 weeks with clear documentation of what is going to happen if the patient goes into spontaneous labor. Spontaneous labor is preferred for vaginal delivery. Planned induction of labor can be considered if there is any obstetric reasons, or if the patient lives too far from the and the distance between their home and the specialist center should be considered. Avoid a 1-2s and a mid-cavity forceps for male babies at risk of hemophilia. FBS, that's fetal blood sampling, and fetal scalp electrode should be avoided in babies expected to have severe or moderate hemophilia. However, for the mild hemophilics, FBS can be considered, especially if this means that a cesarean section can be avoided. Now, this decision is something that needs to be taken by a senior, and if an FBS is performed, then sustained pressure should be applied to that area of the fetal head to stop any bleeding. The plan for intrapartum management and the second stage of labor should all be documented very clearly after discussion with a senior obstetrician. There's no evidence to recommend special measures for delivery in women carrying female fetuses. A female fetus who is at risk of carrying severe hemophilia B may theoretically be more at risk of intracranial hemorrhage and extracranial hemorrhage. How can analgesia and anaesthesia be managed safely? So insertion and removal of epidural catheters and spinal anesthesia, you need factor VIII and IX levels to be more than 0.5 international units per mil. Experienced clinicians should decide on whether central Neuraxial anesthetic can be administered to the patient, and the patient should be given all the information regarding it, and then an informed choice can be made. All carriers of hemophilia should have the opportunity to discuss analgesia with a senior anaesthetist prior to delivery, and a clear plan should be documented in the maternal records. IM injections, intramuscular injections, should be avoided if factor 8 and 9 levels are less than 0.5 international units per mil. They can be given if factor 8 and 9 levels have been maintained in normal range by either clotting factor support or desmopressin. So what is the hemostatic management during labor? So if clotting factor is less than 0.5 international units per mil, then desmopressin can be given to raise factor 8 levels, or factor 9 concentrate can be given to raise factor 9 levels, aiming for 1 international units per mil of the clotting factor. Tranexamic acid can be given for low normal levels or in conjunction with desmopressin to increase factor 8, or with substantive factor 9 treatment. Treatment as close to delivery as possible is recommended. So what is a postpartum management? So obviously it's going to be things to avoid bleeding. So active third stage of management. In an uncomplicated vaginal delivery, factor 8 and 9 levels should be above 0.5 international units per mil for at least 3 days. In an instrumental delivery or cesarean sections following these, factor 8 and 9 levels should be more than 0.5 international units per mil for at least 5 days. Tranexamic acid should be continued postpartum until the lochia is minimal. Pharmacological thromboprophylaxis should be generally avoided where the factor level is 0.6 international units per mil or less, but will need to be considered in women with thrombotic risk factors with careful balance of risks. Following discharge from hospital, the haemophilia center should maintain contact with the patient and should follow them up for an increased period of time post-delivery, and the patient should report to them if they have any increased postpartum bleeding. And what is the neonatal management? So a plan for diagnostic testing of the neonate should be documented in the maternal notes. Cord blood sampling and diagnostic testing for male babies born to mothers who are carriers of haemophilia A and B should be done. In mild cases, this may require retesting at 3 to 6 months of age. For female babies born to mothers who are carriers of haemophilia, no testing is recommended. Parents of neonates diagnosed with haemophilia should be informed of the diagnosis in a timely manner, and arrangements should be done for neonatal follow-up at a haemophilia center. In a neonate with low factor levels, oral vitamin K should be given, and where a blood spot screening test has been carried out on the neonate, sustained pressure should be applied to that area to stop bleeding. In a severe or moderate haemophilic baby, cranial ultrasound should be done prior to discharge. Cranial MRI should be undertaken in neonates where symptoms or signs are suggestive of intracranial hemorrhage, even in the presence of a normal cranial ultrasound. Information on the symptoms and signs of intracranial hemorrhage should be provided at the time of discharge to the parents. Short-term primary prophylaxis should be considered in severe and moderate haemophilic infants who are considered to be high risk of bleeding due to trauma at delivery or prematurity. Right, now this brings us on to von Willebrand's disease, shortened to VWD. So what is the classification and inheritance? So von Willebrand's disease is basically deficiency of von Willebrand's factor. If it's partial quantitative deficiency, it's type 1. If it's qualitative deficiency, it's type 2. And if it's severe quantitative deficiency, then it's type 3. The classification is important because it determines the treatment and the counseling for patients. Inheritance of von Willebrand's disease is autosomal and variably dominant or recessive depending on the von Willebrand's disease type. Genetic counseling about the risk of disease transmission should be offered to patients. So, what are the risks in the pregnancy to the mother and the baby? So, clinicians should be aware that women with von Willebrand's disease have an increased risk of antepartum, primary, and secondary PPH. Counseling about increased risk of bleeding, especially type 1 von Willebrand's disease, where the von Willebrand factor does not rise above zero point 0.5 by term, or type 2 or 3. So these are the conditions where you would expect more increased bleeding. So what is a pre-pregnancy and antenatal management? So prior to conception, the bleeding phenotype should be assessed, historical diagnosis reviewed, and response to desmopressin established. Safe management requires a multidisciplinary approach. All women with von Willebrand's disease should have a von Willebrand factor antigen levels and activity tested, and factor VIII levels checked at booking in the third trimester and prior to any invasive procedures. Women with type 1 von Willebrand's disease who achieve normal von Willebrand factor levels can be safely managed in standard obstetric units in collaboration with the hemophilia center staff. Women with type 2 and 3 or severe type 1 should be referred for prenatal care and delivery to a center where there are specialists in high risk obstetrics as well as hemophilia center. Facilities for laboratory testing of von Willebrand factor and factor VIII levels are essential. Clinicians should aim for factor VIII and von Willebrand factor uh, cofactor basically ratio activity levels of zero point 0.5 international units per mil or above to cover surgical procedures or spontaneous miscarriage. So where invasive procedures are carried and they're required, if von Willebrand factor activity or factor VIII levels are less than 0.5, women should receive hemostatic support in the form of desmopressin where they're responsive, or von Willebrand factor containing concentrates if they're not responsive. Treatment should be with desmopressin in preference to blood-derived factor concentrates. This is safe for use in pregnancy and at delivery, but avoided in preeclampsia. So with desmopressin, there's a risk of developing maternal hyponatremia. So patients should be fluid restricted to only 1 liter of fluid in 24 hours. If additional fluid is required, then electrolytes should be monitored closely. Clinicians should be aware that patients with type 2b von Willebrand's disease may develop thrombocytopenia following desmopressin treatment. If von Willebrand factor replacement therapy is required, a concentrate containing factor VIII and von Willebrand factor manufactured from a safe plasma source with adequate viral testing and inactivation procedures should be used. Target peak von Willebrand factor activity levels should be 1 international units per mil and levels maintained above 0.5 international units per mil until hemostasis is secured. Most antenatal procedures, a single preoperative treatment is sufficient. Some cases, a second dose may be required at 12 to 24 hours. So what is the interpartum management? So the timing of treatment should be as close to delivery as possible, and pre and post treatment levels of von Willebrand factor activity and factor VIII levels should be measured and repeated after delivery or if labor is prolonged. Tranexamic acid should be considered in combination with treatment for all those with von Willebrand factor activity or less than 0.5 international units per mil, or as sole therapy for those with levels more than 0.5 international units per mil if clinically indicated. It can be given orally and IV and can be started prior to delivery. Platelet transfusions plus von Willebrand factor replacement may sometimes be required in type 2b von Willebrand disease. The mode of delivery should be guided by obstetric indications. Spontaneous labor and normal vaginal delivery should be permitted if there are no other obstetric concerns to minimize risk of any intervention. Avoid fetuses at risk of having type 2 or 3 should not have FBS, ECV, FSE application, 1-2s, and mid-cavity forceps. How can analgesia and anesthesia be safely managed? So in type 1 Willebrand's disease, where the 1 Willebrand factor activity has been normalized by pregnancy or treatment, offer central neuraxial anesthesia. In type 2 disease, avoid central neuraxial anesthesia unless 1 Willebrand factor activity is above 0.5 international units per mil and hemostatic defect has been corrected. This may be difficult to achieve in type 2. In type 3, you do not offer any central neuraxial anesthesia. Prior to delivery, opportunity to discuss analgesia with a senior obstetric anesthetist should be offered to the patient. And this should all be documented in the notes so everybody is clear of the plan. Epidural catheters, repeat treatment prior to catheter removal, as the risk of bleeding is no less than when the epidural went in. IM injections and postnatal non-steroidal anti-inflammatory drugs can be given short term when 1 Willebrand factor activity and factor 8 levels are above 0.5 international units per mil. So what is a postpartum management? So in uncomplicated vaginal delivery, 1 Willebrand factor activity and factor 8 levels of more than 0.5 international units per mil should be achieved for at least 3 days. After an instrumental delivery or after a cesarean section, 1 Willebrand factor activity and factor 8 levels should be more than 0.5 international units per mil, but for at least 5 days. Consider tranexamic acid for postpartum period 1 gram 3 times a day or 4 times a day for up to 7 to 14 days. In some cases, prolonged administration for up to even 2 to 3 weeks. If indicated, low molecular weight heparin may be given to inpatients with adequate correction of the ratio and factor 8 levels. If contraindicated, mechanical measures to reduce risk of venous thromboembolism should be considered. Aware of risk of delayed bleeding and encourage the patient to report any excessive bleeding. For women with more severe cases, hemoglobin levels should be monitored and regular contact with the patient maintained for several weeks after delivery. Patients with type 3 1 Willebrand disease may require treatment with 1 Willebrand factor concentrate for 2 to 3 weeks or even longer following delivery. So what is a neonatal management? So again, a plan for diagnostic testing of the neonate following delivery should all be documented, including cord blood sampling in the patient notes. Cord blood samples for 1 Willebrand factor activity should be tested in patients who are in babies who are risk of type 2 and 3 1 Willebrand disease. If they're risk of type 2 and 3, vitamin K should only be given orally unless the 1 Willebrand factor activity has been checked and is normal. Neonates with type 3 1 Willebrand disease should be considered for routine cranial imaging prior to discharge and for short-term prophylaxis with factor concentrate if there has been significant potential trauma at delivery. Okay, so now we move on to factor 11, deficiency. So it's uncommon autosomal disorder, which has both recessive and dominant inheritance patterns. Incidence in the non-Jewish population is 1 in a million. Clinicians should be aware that there is intra and inter-individual variation in the bleeding phenotype. So what are the different phenotypes? So plasma levels of factor 11 show poor correlation with bleeding symptoms. Spontaneous bleeding is rare, even with very low factor 11 levels. However, these patients are often at risk of bleeding following surgery or a trauma. Heterozygotes have mild or moderate reduction in factor 11 levels, Most are asymptomatic, but patients with even mild reduction in factor XI levels may have a bleeding tendency. So, what are the risks in the pregnancy to the mother and the baby? So, factor levels does not usually increase during pregnancy. However, levels should be checked at booking in the third trimester and prior to any invasive procedures. Women with factor XI deficiency may suffer excessive bleeding after miscarriage or termination, especially if they have a bleeding phenotype. There is increased risk of PPH in factor XI deficient women, which is highest in those with a bleeding phenotype and of blood group O, and at least in known O blood group with a non-bleeding phenotype. So the thing about this condition, it's about more about the phenotype. So there's a bleeding phenotype and the blood group is O, there's a higher risk. And the least risk is in somebody who is a non-O blood group with a non-bleeding phenotype. Patients with factor XI deficiency should be assessed for the presence of other potentially compounding factors such as low 1 Willebrand factor levels and platelet dysfunction. No special precautions with baby are required for delivery unless the neonate is at risk of homozygosity or compound heterozygosity. So what are the therapeutic options? The treatment options include tranexamic acid, factor XI concentrate, and fresh frozen plasma. However, women with a non-bleeding phenotype or unknown status can often be managed expectantly. Tranexamic acid should not be given simultaneously with prophylactic factor XI concentrate, as this is considered to increase thrombotic risk. For many women, it is likely that tranexamic acid alone will be sufficient to prevent PPH. If fresh frozen plasma is given to raise factor XI levels, solvent detergent SDFFB should be used when available. Recombinant factor 7A is not licensed for this condition and is generally not recommended except if there is an inhibitor of factor 10. So what is the antenatal, intrapartum, and postpartum management? So factor XI or tranexamic acid is not usually required antenatally unless an invasive procedure is undertaken or if there is bleeding following miscarriage or surgical procedures. Delivery plans need to be individualized. Prophylactic factor XI replacement should be considered if homozygous or / compound heterozygous. Previous history of PPH or general bleeding history. Otherwise, management can be expected with tranexamic acid alone and factor replacement reserved for excessive bleeding. Can central neuroaxial anesthesia be given? So central neuroaxial anesthesia should not be given. Low factor XI levels with a known bleeding phenotype is not clear or severe reduction in levels. So if there's any of this, then you should not be giving central neuroaxial anesthesia. However, if it's a non-bleeding phenotype, then discussion and counseling regarding the risks and benefits of allowing central neuroaxial anesthesia can be discussed with or without replacement of factors. Other congenital platelet function defects. So women with mild platelet function defect disorders may require treatment to cover delivery. Desmopressin and or tranexamic acid can be used to cover delivery. Tranexamic acid should be continued postpartum until lochia is normal. Patients with mild platelet function defects such as storage pool disease, signaling defects, or ADP receptor abnormality do not usually bleed spontaneously but require treatment during hemostatic challenges. Central neuroaxial anesthesia should only be given if the risks are considered to be outweighed by the benefits and the hemostatic defect has been corrected. A platelet transfusion may be necessary beforehand, and epidural catheter should not be left in situ. Rare bleeding disorders, which include things like inherited deficiency of fibrinogen, factor 2, factor 5, factor 7, factor 10, factor 11, and factor 13, combined factor 5 and factor 8 deficiencies, and congenital deficiency of vitamin K dependent factors. So what is inheritance of factor 2, 5, 7, 10, 13, and combined factor 5 and 8 deficiencies? So genetic counseling should be offered to these patients. Understand that these most rare inherited bleeding disorders are autosomal recessive in inheritance, and heterozygous carriers are usually asymptomatic. For affected women or asymptomatic heterozygous carriers, consanguinity should be established because they are more at risk. Screening when possible, and formulation of a delivery plan for a potentially affected baby. So, what are the risks in pregnancy to the mother and the baby, and what are the treatment options? So, management should take into account both the factor level and whether there is a clinical history of bleeding. Factor replacement therapy is usually advised for delivery in women with severe coagulation factor deficiency and or bleeding history. Tranexamic acid at a dose of 15 to 20 milligrams per kilo or 1 gram 4 times daily alone can be used for minor bleeds and in combination with factor replacement. If the baby is at risk of severe deficiency, the delivery plan should include avoidance of 1-2s, mid-cavity forceps, FBS and FSC. Central neuraxial anesthesia, postpartum pharmacological thromboprophylaxis, and NSAIDs should usually be avoided in women with severe deficiencies, as it may be difficult to guarantee consistent normalization of hemostasis even after treatment. They may be used after individual assessment if adequate replacement therapy is confirmed. Prothrombin, that's factor 2 deficiency. So factor 2 activity less than 0.2 international units per mil, and there is significant bleeding, and the patient is in established labor or prior to cesarean section, they should have prothrombin complex concentrate at 20 to 40 international units per kilo to achieve factor 2 activity of 0.2 to 0.4 international units per mil. Consider further thrombin complex concentrate of 10 to 20 international units per kilo at 48-hour intervals to maintain factor 2 activity more than 0.2 international units per mil for at least 3 days. Women already receiving prophylactic prothrombin complex concentrate can continue it throughout the pregnancy. So for factor 5 deficiency, for significant bleeding or delivery, factor 5 activity less than 0.2, 15 to 25 mils per kilo of FFP should be considered once in established labor or before cesarean section to achieve factor 5 activity of between 0.2 and 0.4 international units per mil with further FFP 10 mils per kilo at 12-hour interval to maintain factor 5 activity of more than 0.2 international units per mil for at least 3 days. Where possible, solvent detergent FFP should be used to reduce infective risk. For severe bleeding or cesarean section, additional platelet transfusion may be required. Severe factor 7 deficiency, so factor 7 activity of less than 0.2 international units per mil in the third trimester with prior history bleeding, consider recombinant factor 7A 15 to 30 micrograms per kilo every 4 to 6 hours for at least 3 to 5 days following cesarean section. For mild bleeding, tranexamic acid at 15 to 20 mils per kilo or 1 gram 4 times a day can be used. For severe bleeding, recombinant factor 7A 15 to 30 micrograms per kilo can be given and repeated if required every 4 to 6 hours, usually for a minimum of 3 doses. Severe factor 10 deficiencies. Factor 10 activity of less than 0.3 international units per mil in the third trimester with history of bleeding and need cesarean section. Use prothrombin complex concentrate at 20 to 40 international units per kilo to achieve factor 10 activity more than 0.4 international units per mil. Further prothrombin complex concentrate at 10 to 20 international units per kilo once daily to maintain factor 10 activity of greater than 0.3 international units per mil for at least 3 days. Antenatal prophylaxis may be considered in women with history of recurrent bleeding or adverse pregnancy outcome using prothrombin complex concentrate at 20 to 30 international units per kilo 2 to 3 times a week to maintain through factor 10 more than 0.01 international units per mil. Severe factor 13 deficiency. So during pregnancy, prophylaxis of factor 13 plasma concentrate or recombinant factor 13. Dosing frequency should be increased from every 28 days to every 14 to 21 days to maintain factor 13 levels of more than 0.2 international units per mil. For delivery, additional factor 13 concentrate at 10 to 40 international units per kilo once in established labor or before cesarean section, depending on the interval since last prophylaxis. Factor 5 and factor 8 deficiency combined. So combined factor 5 and 8 deficiency. If factor 5 activity is less than 0.2 in the third trimester, consider solvent detergent FFP at 15 to 25 ml per kilo once in established labor or before cesarean section to achieve factor 5 activity of between 0.2 to 0.4 international units per mil. Consider further solvent dependent detergent, FFP 10 ml per kilo once every 12 hours to maintain factor 5 activity more than 0.2 international units for at least 3 days. Consider additional recombinant factor 8 if the factor 8 activity is less than 0.5 international units per mil in the third trimester. Fibrinogen disorders. So, what is the nature and inheritance of these disorders? Um, so you've got clinicians should be aware that fibrinogen disorders can be autosomal recessive or autosomal dominant and are associated with variable clinical phenotypes. So what are the risks in the pregnancy to the mother and the baby? Clinicians should be aware that severe fibrinogen deficiency may be associated with bleeding, but quantitative and qualitative deficiency can also be associated with thrombosis and pregnancy loss. So, what is the management of for pregnancy and delivery? So, if functional fibrinogen is less than 0.5 grams a liter, consider prophylaxis throughout pregnancy and fibrinogen concentrate initially given at 50 to 100 milligrams per kilo twice per week, adjusted to maintain through fibrinogen activity more than 1 gram per liter. High doses of fibrinogen concentrate are likely to be required to maintain fibrinogen activity as pregnancy progresses. Consider additional fibrinogen concentrate for established labor to ensure fibrinogen activity of more than 1.5 grams per liter for at least 3 days. Tranexamic acid can be used for minor bleeding. Because of the variable clinical phenotype associated with hypofibrinogenemia, and dysfibrinogenemia, a personal and a family history is required for management decisions. If there is no personal or family history of bleeding or thrombosis, expectant management is recommended for pregnant women or the neonate. Fibrinogen replacement therapy is associated with high risk of thrombosis and requires vigilance. Pregnant women with a thrombotic phenotype or other risk factors for venous thrombosis and with a low risk of bleeding should be considered for thromboprophylaxis with low molecular weight heparin. Central neuraxial anesthesia, NSAIDs, and intramuscular injections should generally be avoided for women with severe fibrinogen deficiency or a personal or family history of bleeding due to the difficulty in assuring correction with factor concentrate. They may be used after individual assessment if adequate replacement therapy is confirmed. The use of mid-cavity forceps, rotational forceps, 1-2s, FBS, and FSC should be avoided in a baby who is at risk of fibrinogen deficiency associated with a bleeding phenotype. Platelet function disorders. It's important to know that the first time that this may present might be in pregnancy with bleeding. Pre-pregnancy counseling is advised. An MDT approach with expertise in managing platelet function disorders is recommended. So Bernard-Soulier syndrome is BSS for short. Genetic abnormality in platelet adhesion receptor and associated with severe bleeding phenotype. It's autosomal recessive. In areas of high consanguinity, it may be prudent to test further using platelet low cytometry for the specific GP IB surface density. BSS is associated with a significant risk of primary and secondary PPH and wound hematomas. Management of delivery and therefore requires quite careful planning with the MDT team. Peripartum hemostatic management should be guided by the assessment of the individual phenotype. Patients with a bleeding history should be given a platelet transfusion prophylactically at delivery or before cesarean section in combination with tranexamic acid. Platelets should be human leukocyte antigen, so HLA matched, where possible to reduce risk of alloimmunization and platelet refractoriness. Tranexamic acid should be given at the onset of labor and continued regularly through the postpartum period until low is normal. Desmopressin has variable efficacy and is unlikely to be useful as sole therapy in BSS. Central neuraxial anesthesia should be avoided. So this is another one, which is Glanzmann's thrombasthenia. GT for short is a disorder of platelet function. It's autosomal recessive, and it can cause severe bleeding tendency. What are the maternal risks? So a significant risk of intrapartum and PPH, and plan is needed for labor and delivery. HLA matched platelet transfusion and or recombinant factor 7A should be given prophylactically at delivery for patient history of bleeding. Repeat doses may be required depending on the clinical picture. Tranexamic acid should be given from the onset of established labor and continued regularly through the postpartum period until lochia is normal. Central neuraxial anesthesia should be avoided. So what are the risks to the fetus? So maternal alloimmunization to paternally derived fetal platelet antigens may cause fetal thrombocytopenia and risk of intracranial hemorrhage and other fetal bleeding. If fetal maternal alloimmunization does not occur, there's no need to restrict aids to delivery. What are the treatment options? So platelet-specific alloantibodies should be checked at booking at 28 weeks and 34 weeks. If fetal maternal alloimmunization occurs, fetal medicine unit with experience of these condition, the patient should be referred to, and treatment with intravenous immunoglobulins with or without steroids. Amniocentesis and with platelet typing may be considered in cases of platelet heterozygosity. If the baby is at risk of homozygous GT or fetal-maternal alloimmune thrombocytopenia, restrictions to delivery should be applied. As for all babies at risk of intracranial hemorrhage, these include avoidance of one-chews, mid-cavity forceps, FSC, and fetal scalp sampling. Depending on the risk, an elective cesarean section may be considered. Neonatal care of potential alloimmunization requires a cord platelet count and withholding intramuscular vitamin K until the result is known or administering it orally. A platelet count below the normal range should be repeated at day 3 and 5. At day 3 to 5 when the platelet nadir is reached due to development of the neonatal spleen. Platelet transfusion should be given if the platelet count is less than 30. So other congenital platelet function defects, what are the therapeutic options? So mild platelet function disorders require treatment to cover delivery. Desmopressin and a tranexamic acid can be used. Tranexamic acid should be continued postpartum until loci is normal. Central neuraxial anesthesia should only be given if the risks are considered to be outweighed by the benefits and the hemostatic defect has been corrected. Platelet transfusion may be necessary beforehand and epidural catheter should not be left in situ. Management of women with inherited bleeding disorders who request termination of pregnancy. You will be very pleased to know that we are almost at the end of the presentation. Please give this video a thumbs up and subscribe to my channel so you can keep yourself updated, and also it encourages me to do more of these videos for you. So, management of women with inherited bleeding disorders who request termination of pregnancy. So, if it's medium or high bleeding risk, requires MDT management in a unit with a 24-hour access to blood products, factor replacement, and specialist hematological advice. Factor levels should be measured in hemophilia carriers, women with von Willebrand's disease, and women with known factor deficiencies, factor 7, 10, 11, and 13, prior to medical or surgical termination. Factor levels should be corrected to those indicated for labor with treatments outlined above and maintained for 24 hours post-procedure. Bleeding post-procedure should be closely observed as an inpatient, and similar treatment outlined for postnatal management should be employed. Open access to gynecology units and hemophilia centers must be arranged for those at risk of bleeding, as the risk of bleeding can continue for several weeks. Right, so now I've got some tables from the guideline. Again, this just summarizes everything that we've really discussed, but in a table format. So So high risk of bleeding, medium risk, mild risk. So high risk are the patients who are type 3 von Willebrand's disease, severe rare coagulopathies, severe platelet function disorders, hemophilia carriers with a significant bleeding history. So, suggested management of delivery, so adequate replacement therapy to be given after the onset of established labor, avoid central neuraxial anesthesia unless adequate replacement therapy has been confirmed, maintain normal levels for at least 3 days postpartum or 5 days after a cesarean section or instrumental delivery. Medium risk is the type 2 von Willebrand's disease, mildly reduced third trimester maternal levels of factor 8, 9, or 1 Willebrand factor activity, factor 11 deficiency with clinical bleeding phenotype. So, for these, adequate replacement therapy given after the onset of established labor, avoid central neuraxial anesthesia unless adequate replacement therapy has been confirmed, maintain normal levels for at least 3 days postpartum or 5 days after a cesarean section or instrumental delivery. Mild risk is the mild platelet dysfunction disorders, carriers for hemophilia with the third trimester factor 8 and 9 levels of more than 5.5 international units per mil, type 1 von Willebrand's disease with corrected von Willebrand's factor activity of greater than 0.5 international units per mil. So consider tranexamic acid for delivery and postpartum. Unlikely to be at risk are these: so rare coagulopathies without bleeding phenotype and factor 12 deficiency. So no replacement therapy is needed. Able to have central neuraxial anesthesia. So this one again is the table that is again stratifying the risk according to high risk, medium risk, mild risk, but this time it's for the baby and what to avoid. So for the high risk patients, which is males with severe and moderate hemophilia A or B, type 3 von Willebrand's disease, severe rare coagulopathies or severe platelet disorders, consider third trimester amniocentesis to diagnose the condition. Discuss mode of delivery taking maternal and fetal factors into consideration, but avoid mid-cavity forceps 1-2's delivery, FBS, FSC, rotational forceps, and external cephalic version, cord sample for factor assay, oral vitamin K unless the result is known to be normal. For the medium risk, which is males with mild hemophilia A or B, type 2, von Willebrand's disease, consider third trimester amniocentesis to diagnose disease, avoid mid-cavity forceps 1-2's, rotational forceps, and external cephalic version, judicious use of FBS and FSC to facilitate vaginal delivery, cord samples for factor assay, oral vitamin K unless the result is known to be normal. Mild risk is the clinically moderate or severe type 1 von Willebrand's disease in the family, female fetuses who are obligate or possible carriers of severe hemophilia B, mild platelet function disorders. Consider avoidance of 1-2's and external cephalic version, judicious use of rotational forceps, FBS, and FSC. Unlikely to be at risk are the clinically mild type 1 von Willebrand's disease in family, all other obligate possible hemophilia carrier female fetuses, heterozygous rare coagulopathies, no special precautions. So this is a table which is looking at the procedures, the timing, in number of gestation, the weeks of gestation, important information and recommendations. And I will leave this for you to read. And this is just the table continued. Okay, so this is a table where it talks about neonatal bleeding risks and how to manage it. Again, it's quite a comprehensive and it's quite a good table, but I think it's more for information because I don't think we need to know so much in detail as to how to exactly manage all the different fact deficiencies in the baby because it's generally done by the neonatal doctors, but it's good to have a general idea, so I'll leave this one for you to read as well. So that's it then. That is the completion of the inherited bleeding disorders in pregnancy guideline. As I said, I've worked quite hard on this guideline to simplify it for you, and I hope you found it easier to understand. Please don't forget to like this video and share it with your friends, and subscribe to my channel if you haven't already. And please comment and let me know how useful was this video to you. And I hope you've enjoyed listening to this.